We move on now to the last talk of the day, and this is going to be given by Alfred Spira from the French Academy of Medicine. And as I said, Alfred has been pivotal in organising the conference on health inequalities in Paris, and he's going to talk about access to healthcare in European countries. Alfred.
Thank you. Okay. Good evening, everybody. Thank you for the invitation, and thank you to Professor Freud for organizing this very interesting meeting. As George Griffin just said, I will be very short. I'm not going to speak 20 minutes, even in English. We are organizing together with Phil Medalea and our colleagues here a conference in Paris on the 22nd of January on health inequalities. If you are interested, it will be in French and in English with simultaneous. I'm finished. I had only one more slide. This is my last slide. Okay. So you are welcome to come in Paris, and if you wish, you can find all information on the website of French Academy of Medicine. Okay. As I thought that we would be late, I just put my key messages on this slide. I have two messages. As we heard many times from this morning, all international and European instruments recognize the right for everyone to enjoyment of the highest attainable standard of physical and mental health. And mental health is really the most important problem. And all European members, state members, including UK, recognize these basic human rights, but access to national healthcare services is completely different from one European country to the other, and I can say from one country to the other in the world. For instance, between the US and Canada, it's absolutely completely different. So there is a high diversity for migrants and refugees, and I think that this could be or should be improved. My second message is that national health information systems should, but they don't, communicate basic personal health information, health data between them, because migrants are migrant people. They very often move from one country to the another, as Manuel Carvalho called them, they are on the move. But the health data, health personal data, are not on the move. And this is really a scandal to me, since, as you know, all migrants who are entering in Europe put their fingerprint on files, and these files and their fingerprint are used to follow them and to find them where they are. And when they are identified in a country, they give their fingerprint, and immediately the police can know where they entered and when they entered. So their personal data exists. Their health data should be transmitted from one country to the other, of course, taking care of privacy and not disclosing this information to any other professional than the police. But this could exist and should exist. It doesn't exist. Well, I will not go back to this. You already have seen it many times from this morning. Just to stress one point, during the last 4 to 5 years, immigration concerned 4 million persons in Europe, in a continent of, I don't know, 350 million, something like this, which means that this represents 4 to 5% of the population as a stock, that there is a flux. All these people do not remain as migrants, they are integrated in countries. And the main problem concerning health concerns undocumented migrants, which represent 0.4 to 0.8 of total population. I cannot believe that we do not have the financial means and legal means to take care of these persons according to the international and legal entitlements which all countries in Europe at least agree and have ratified. The UN International Convent from 1966 saying that the right for everyone to a sustainable standard of physical and mental health, and of course the European Directive of 2013 saying exactly the same thing. So with international documents, international regulations, we have the means to do this, and we do not do this. We do not do this. This means that in Europe, despite the fact that all member states ratified the international conventions, access to health care for migrants is a national competence, and it depends on the legal status of the persons, undocumented migrants or asylum seekers or refugees, and it depends on national regulations which can vary from no rights to health care at all, or while paying large amounts of money, to minimum rights, or to rights for primary and secondary care. So I will try to show you very quickly what was the situation. Before this, I would like to stress, I will come back on this, I will stress the difficult role of NGOs, because finally, primary care is very, very often under the responsibility, under the decisions which can be made by these persons when they go and visit NGOs, especially Médecins du Monde and Médecins Sans Frontières and others, a lot of NGOs. For instance, in France, there are more than 1,500 NGOs taking care of these persons. NGOs are facing a paradox. If they provide care, they may act against legal and financial regulations of the country. But if they don't provide care, they violate human rights and exclude the most vulnerable. This is an untenable situation. This is really a paradox. And as we all know, NGOs are acting instead of public services and states who are failing their mission towards these persons. When doing this job, and a lot of people here, I'm sure I like thousands and thousands of persons who are volunteers in NGOs in different kind of settings. We know that we have to take care, to take into account two things. First, this has already been stressed, what we epidemiologists call the healthy migrant effect. Migrants are usually young people. They were used to be men, now it's 51. In France, we have 51% of men and 49% of women. They are stronger and more resourceful as the population of places where they come from, and they are healthier. the other thing is that we must, and the states should take into consideration that there are particular health determinants such as the country of origin, the reasons for migration, the socioeconomic status, age and gender, the journey. All this has been already developed, but I think that the way in which these persons are allowed to access to the health systems in the different countries should take into account this information, which is very important. So very briefly, and this comes from the WHO report on the health of migrants and refugees. Here you see the different European countries according to the kind of access for undocumented migrants. And you see immediately the heterogeneity. There are, according to WHO, but this can be discussed of course, 5 countries which have full access. This include Switzerland, which is not in the EU, but it's a European country. And as the entrance in Switzerland is very easy, at least from France, it's important to put this Switzerland in this chart. Partial access for some country, which is not far from full access, and for the other countries, there is no access. So then it depends on the ability of different local medical services, medical professionals, or NGOs to work with these persons. This is another way to say almost the same thing. This comes from a very important publication made by Catherine O'Donnell, showing that she classified countries according to the fact that emergency care and primary or secondary care were accessible for free or with payment in the countries. And you see the picture, there is a large group of countries for which emergency care is free and with payment for primary and secondary care, but we find countries in all these 6 boxes here, which means that there is really a very important variability and diversity among countries, which is really almost impossible to understand from a health point of view, because the persons going in the Netherlands or in Denmark are, I'm sure, exactly the same persons, but they don't have the same rights in countries which have approved the same treaties and the same international regulations. Well, I'm not going to develop this because it's late, but in France, for instance, we have a rather good system, a rather generous system. We have what we call aide médicale d'État, which is not far from aide médicale d'urgence in Belgium, but aide médicale d'État is even better. But now, the French government has only one objective, is to limit the access to aide médicale d'État, or to limit to access to health for asylum seekers and refugees, because for these people in France, once they have filled in their file, they have access like regular citizens from the day they have filled the file to ask for becoming refugees. So the French government is now working very hard to try to limit these rights, the cost of which, the cost of these rights is exactly 0.47%, less than 0.5% of the total health budget for about between 300,000 and 500,000 persons. Nobody knows. So they represent 0.5% of the French population and the cost for them is 0.5% of the budget, which means the regular budget for human beings living in France. Of course, these persons are human beings. In Germany, the system is quite different. I'm not German, and just trust me, it's very difficult to disentangle the systems existing in different countries. You know very well it in Belgium, you are federal states. In Germany, there are Länder, and from one land to the other, the regulation can be very different. But the system in Germany is less generous than in France. And once again, this is very difficult to understand because France and Germany are very close countries, and I'm used to call them brothers and sisters, or two brothers, because we happily the last war will be one century old in a few years. There are barriers to receive care in all these countries, including the most generous countries like Italy, Spain, Belgium, or France, or the Netherlands. The lack of entitlement is the most important barriers. Other barriers are the health profiles, the awareness of chronic diseases risk among migrants, the awareness of the organization of health services in host country, for instance, and there is one GP, French GP in the room, I don't know if he's still there, but believe me, usual GPs in France do not understand anything about the system, which is too complicated. It's not their job to classify people according to administrative categories. So what do? A regular doctor will take care of a person and try to be reimbursed, because if someone has no money, cannot pay, the doctor can be reimbursed. Other doctors will say, well, it's too complicated, please, I will take care of you, and this is it. Come back when you need. And the other doctors will say, well, I'm sorry, it's too complicated, I have no time, and I'm not going to take care of you. Goodbye. This is finished. The last opportunity represents about 10% of medical doctors. The second opportunity of doctors saying, well, I'm going to take care of you, represents also about 10%. I have no actual figures, but so the situation is really difficult. The fact is that finally, if these persons are ill, are sick, and if they need care, they will receive care from health professionals, medics or other nurses or other professions. So finally, and this is the same in all European countries, we are in developed countries, and every health professional, each health professional is going to take care of ill and sick persons. So there is something completely very difficult to understand, at least for me, because we know that they need care and they will receive this care, but national regulations are not designed in such a fashion. NGOs already said this, have a very decisive and important role of this, and they must really be acknowledged for their job and what they're doing. The problem is that they are acting more than they should do, because they are doing the job that the state, the government, is not doing. So they are acting as volunteers, they are acting for free, and they are acting to compensate what the government governments do not do, and this is really a problem. All this could be improved by increasing awareness, by helping these people to have access to interpreting services or to electronic devices. For instance, all migrant people, have smartphones, like you and me, of course. And I'm always surprised to see that smartphones and applications are not enough used to help these people to have access to health and translation. Information, education of migrant persons, but of health professionals is very important. And finally, but I began with this exchange of information. Okay, the bibliography is very easy to find, and I hope to see you on January in Paris. Thank you very much.